I know that was a short break. But we want to get started in this session. So the next 90 minutes will be entirely Q&A with our panel. We have the questions that some of you turned in on the cards during the break, and we also have some questions that people submitted during registration, and our moderator has those questions. So we'll spread those throughout, but there will also be mics around the room during the whole session. So if you would like to ask a question, just raise your hand and then wait for the mic to come to you so we can make sure that everyone in the room can hear your question and everyone on the live stream can hear. So I'll turn it over to our moderator, Dr. Chris Heery.
Thanks, Shannon. So I think we start out with introductions for everybody. I'll start with myself, and then I'll just let everyone introduce themselves. I'm Chris Heery. I'm a medical oncologist by training. I unfortunately don't see patients anymore. But for a while, I was taking care of a lot of chordoma patients at the NCI. And then we'll start with Dr. Raza.
Hi, good morning. Good morning, everybody. I'm Sean Raza. I'm a skull-based neurosurgeon at MD Anderson in Houston.
Good morning, Shannon McDonald. I'm a radiation oncologist in Boston.
I'm Joe Schwab. I'm an orthopedic surgeon, formerly of Mass General and soon to be at Cedars-Sinai in Los Angeles.
Good morning. My name is Yenlin Chen. I'm a radiation oncologist at the Mass General Hospital.
Hi, good morning. Shreyas Patel. I'm a medical oncologist. I treat bone and soft tissue tumors at MD Anderson.
Hello again, everybody. Dan Freed, translational researcher from the Chordoma Foundation.
All right, so we have an incredible panel of experts that range across the different treatment modalities and the methods that are going to be used to manage chordoma across the natural history of the disease. We really want to encourage anyone, if a new idea comes into your head that you didn't have time to write a card, you're welcome to ask a question. There will be microphones available. But I did want to define some terms first, just to make sure that everybody's level set on a few things that people are going to refer to throughout the conversation so that people aren't lost and saying, like, well, what is that? So first things first, we are going to assume when we say newly diagnosed that we're talking about localized disease. That isn't always the case, but it usually is the case. And so for the purposes of this conversation, for the most part, when we talk about newly diagnosed patients, we're going to be talking about a local intervention like surgery or radiation, something like that, that might be able to eliminate that disease. Around those local interventions, there's a term that you might hear in other cancers that we haven't yet really gotten to with systemic therapies, and I'm gonna have to define systemic therapies in a second, that is a term called adjuvant therapy. If you haven't heard that, that is a therapy that is used sort of after a local intervention. That is, the purpose is to try to increase the likelihood of cure. There's also something called neoadjuvant therapy, and that is a therapy before local therapy, also to try to reduce the size of the tumor so that when you go for that local therapy, your chances of it completely removing all the tumor is higher, okay? So neoadjuvant is before local intervention, adjuvant is after, and sometimes there is neoadjuvant followed by adjuvant therapy too. So we might get into that, we might not. But you might wonder, what is systemic therapy? A systemic therapy is a therapy that you give to the whole body, and it'll address the tumor wherever it happens to be. Why is that important? Because sometimes we think we know where a tumor is, looking at imaging, and then it actually has already spread somewhere else before we get in there, right? So it's sometimes very important to use a therapy that can go everywhere to address the tumor cells wherever they might be, okay? A couple more. Surgery, I'm assuming everyone knows what that is, but it's important to note that surgery is different in different parts of the body. So there are going to be some comments that we talk about for sacral chordomas versus brainstem chordomas, where surgeries have a lot of different decisions that need to be made. So we'll try to parse some of that out from some of the questions that come up. And then there's a term ablation, which some of you may have heard, may have never heard. And that is using something like a needle that can be put into a site of disease to sort of fry it or freeze it. something like that, that would actually eliminate something right in one spot. That's not something that you can do for a disease that's spread lots of places in the body, but if there's something that's painful or pushing on something, that kind of approach could be used for something like metastatic disease. I guess I should define metastatic. We heard it in the last talk, but metastatic just means it is spread beyond where it started to some other part of the body. All right. Any other terms that you've heard during this morning that you're afraid to ask, that you'd be embarrassed? Go ahead and raise your hand if you're, seriously. That is the purpose of this meeting. So if there's something that you say, like somebody says a word and you don't know what it is, please raise your hand and we'll come back to try to answer that, okay? All right, so we're gonna start out with a really broad question that was asked leading into a prior conference. And the question is for everybody on the panel. What is something that you wish more patients did or did not do at some point in their treatment journey? It's super broad, so anyone can start wherever you'd like. I'll let you think about it for 1 second while I take a sip of water. I know no one wants to start to answer that question.
I can start.
All
As
right,
a
great.
radiation oncologist, we sometimes see
Wait,
patients.
I'm sorry. Can everyone introduce just remind everybody, just like you just did, just remind of their skill set when we start, because that'll help frame it. Thank you.
Great. Yeah. So, yeah, as a radiation oncologist, I see some patients that come following a biopsy or surgery by someone that doesn't have experience, doesn't know the disease, or perhaps doesn't even know on imaging that a chordoma is a possibility. And that's something I wish all patients would do due diligence and research, and their physicians who are seeing them would as well, to make sure that the patient finds a good surgeon experienced in this disease.
I'm a neurosurgeon. I'm going to echo that comment. I think one of the biggest obstacles that we see for patients that have been recently diagnosed is that they were often diagnosed based on imaging and rushed to surgery locally, and they didn't have an opportunity to do their due diligence and do their research. And then the challenge becomes trying to sort of offer that operation they should have had to begin with. So I think education and research, I think, is important.
Yelin Chen, radiation oncologist. So just would further expound on that, in that some of the situations that we see that, and the reason why we would like patients to have had the proper initial biopsy or surgery is that there is a risk that is, I think, a bit unique to chordoma and these soft and bone tissue tumors that are a bit different than some of the other much more common cancers or sarcomas, and that these tumors have the ability to contaminate or seed. And that is particularly important along the spine or in the pelvis. The larger the surgical field of exposure, the greater the potential area that if a surgery is incomplete or marginal, the tumors can potentially see there. And as a radiation oncologist, the challenge it poses for us is that we would then have to treat a much larger area in order to sterilize the area that potentially might have been exposed. So just as an example, if someone had a spine chordoma and they've had front and back surgery, we would have to chase all the levels of stabilization or incision or drain side, and there are even areas that we can't even possibly address. For example, the lung cavity where surgically might have been exposed. So a proper sequencing of treatment, diagnosis, and biopsy is very important.
I think summarizing all of these things, the guiding principle is you get one good shot at cure. You have to take your best shot the first time around. And that requires the experience and expertise of multiple different disciplines represented on this table. So the simple way of describing it is that all the thinking needs to happen first before the doing starts. If the doing has started already and then the thinking comes in, there's usually a problem there somewhere, right? So I think getting all opinions from the right people up front minimizes the risks of failure to the extent humanly possible. Joe, you were saying something.
Yeah, I was just going to, I agree with what everyone has said. The struggle, I think, is, most patients go, like myself, when I'm a patient, I go to a doctor, and I'm relying on the doctor to give me the information. And so it's hard for patients to be able to think that they know more than the doctor. And I don't want patients to come to me and think that they know more than I do as well. So it's a bit of a hard situation. And really the onus is on us as medical specialists to educate our colleagues to know, hey, listen, this should be sent somewhere else. So it's very hard for patients to do that, even though we are saying this from the perspective of we want the best for the patients, and we want them to come to see us first because we think we provide good care. But I know the doctors that everyone else has seen that have done these surgeries, they felt the same way as well. They weren't doing something maliciously. They may just not know because they're rare tumors. So it's very difficult.
Yeah, those are great comments. So I think just to summarize very quickly on this particular point, this isn't unique to chordoma at all. Similarly, with other curable cancers, breast cancer, colon cancer, lung cancer, certainly prostate cancer, these are all tumors where the chance of cure is completely at the beginning. And so if you don't have a multidisciplinary team, this is for anybody who has anybody with any cancer in their life, if they're newly diagnosed with cancer, find experts who are multidisciplinary to talk through the case before you start anything. And certainly is true for chordoma, although a bit more difficult with chordoma, and that's why the Chordoma Foundation exists, to help people find those right people. And obviously, you have a panel of people here that represent the institutions that are capable of doing that. There are other institutions as well. So please make sure that you disseminate that as best you can amongst the community. Now, a lot of the questions we got that are cards from some of you all are a bit more specific. So I'm going to start with sort of try to put them in the order of the disease, how the disease progresses through time. So I think this is a great one that a lot of people are wondering, has there been any change in the likelihood of recurrence of chordoma with a great en bloc resection from, say, today versus 20 years ago or 30 years ago? Has there been any significant movement in that? And if you could sort of estimate what is the likelihood depending on the quality of the surgery, I guess that would probably be Dr. Schwab. I don't know. I'm not sure who would start with that.
I think one thing to say just is that there is still bias, right? Even amongst the different centers that treat patients with chordomas, there are disagreements about how best to manage. And I'm sure the patients have seen that when they've gone to different these centers, they get a little bit of different opinions. So what's the right answer? And it's part of its belief, I would say. At Mass General, we have worked very closely with our colleagues from radiation oncology, and we believe that giving radiation up front does help with local control. And so we combine preoperative radiation with what we think is good surgery, and I'm not talking about skull base because that's not my area, the spine and the sacrum, the combination of radiation up front with surgery, and when I say surgery, I mean trying to remove the tumor with negative margins, and then postoperative radiation. And we have the data that we have are good with that regard, but we don't have a comparison group, and that's the real difficulty. So we can't definitively say that we're right. We believe what we're doing is right, and that's why we do it. But people disagree with that.
And Dr. Raza, could you comment from the Clybold?
Yeah, I think from the skull-based perspective, I think it's been very promising that over the last decade or so, we have seen improvement in outcomes. The anatomy of the skull base is such that, there's arteries and nerves that course through that bony floor, and then right below the skull base, you have the basement where there are all these different compartments. And over the last 10 years or so, surgery's evolved so much where each one of those compartments can be accessed safely with less morbidity. And then certainly, with the addition of radiation therapy selectively has also improved outcomes. And I think a lot of the high volume centers, when we compare our outcomes to previous surgical strategies and without the inclusion of radiation therapy, things have gotten better, not only in terms of local control rates, but quality of life too. There's still a lot more work to be done, but I think there's been a lot of improvement. And that's also helped us reframe how we think about recurrence. because of how surgery's evolved over the last 10 years. So situations where we didn't think we can get a complete resection, we can get a complete resection. So I think it's been great in terms of the improvements we've seen over time.
Can I just add one more thing? One of the biggest changes that I've seen in my career at Mass General, specifically surgically, relates to reconstruction. Because we do believe the use of radiation is important for local control, we use radiation, and that certainly impacts the ability for the reconstruction when it's needed, particularly in the spine or in high sacral tumors. We had found that our reconstructions were failing because the bones were not healing. In part because these are big surgeries and the surgery devascularizes the area, and in part because we use radiation, and radiation also can negatively impact the bone healing. So what we started to do roughly 10 years ago or so was we use vascularized tissue. So we'll use a vascularized fibula, or more recently, when possible, we'll use a rotational rib graft, the patient's own live bone. And that has made a big difference in terms of our ability for the reconstructions to heal, and so you can avoid some of the hardware failures that we had experienced before then. And that, I think, has been a big change in our surgical practice related to our combination of surgery and radiation.
Yeah, maybe could the radiation oncologist also just talk through then, all right, let's assume there is a clear resection cavity and the risk reward of the choice about radiation, and then also in the scenario where there is not a totally clean resection. And because some of the questions are also asking about how am I going to expect to recover with radiation, et cetera. Maybe you could touch on just some of those topics broadly in that upfront setting.
So in the skull base, we typically do recommend post-op radiation. There are some studies out of UPMC showing some favorable characteristics of some tumors where maybe we could avoid it, or very small tumors, especially in young children. But in general, we recommend it. For the base of skull, it's hard to get an en bloc resection. You're usually not able to get clear margins around the tumor because it's adjacent to very critical structures. And then for the spine and sacrum, as Dr. Schwab mentioned, our standard is often to give radiation before. We think it decreases the risk of seeding. Our surgeons tell us it makes their surgery easier, so we typically do use radiation in those cases. But in other institutions, surgery alone with an en bloc resection, if the margins are widely negative and that's done up front, is sometimes considered an efficacious therapy. And because of the rarity of these tumors and the difficulty in comparing two different groups, because most institutions have one philosophy, it's difficult to say.
Yeah, just to kind of complement that a bit, just in terms of recovery, so for patients who undergo preoperative radiation, there typically is a month of recovery time for skin reaction to resolve, for the deeper tissues to be able to heal better. But what's important is always just that upfront discussion with our surgeon. Based on the extent of the tumor, we might discuss things such as, like, would the patient likely have a plastic surgery with healthy tissue flap that we brought in, and that would help us determine how much preoperative radiation to give. So, for example, we could give 2 weeks of preoperation or up to 5 weeks, and sometimes we tailor that based on the extent of surgery, complexity of it, and the reconstruction. And we have found that, although there are no big randomized trials for chordoma, we have had 2 prospective trials over time using both using some form of proton-based therapy, and within those trials, patients have had preoperative radiation or post-operation, a variety of scenarios. And looking back at that and looking at patients who've had different sequencing of treatment, the patients who do have some form of preoperation seem to do a bit better than purely postoperative, but it depends on the margin. And then there are some patients who undergo just radiation. But the key thing is that the quality of the surgery and the radiation sequencing both are very important. And then just another word about kind of recovery from all of this when all the treatment's done. One of the really gratifying collaboration that Dr. Schwab had over years is based on Dr. Schwab's observation and our kind of deep dive into our outcomes for our patient. We noticed that patients do have fairly high fracture rate. And we do think that certainly in part has to do with what level of the spine the tumor involves, but also has the preoperative radiation and the overall high dose radiation impacts, results in a fairly high insufficiency fracture risk. And with that, I've seen them, do stabilization, anticipation of that potential risk, and for us too, it's helped us tailor our radiation. And so one of the things as we advise our patients in their subsequent recovery is to avoid like certain high impact risky sports activities and physical activities that might exacerbate that fracture risk, and also just warning patient about when to anticipate that, because it typically is highest risk within that first 1 to 2 years, and the risk goes down further. So those are some of the things regarding how we, despite the potential challenges of radiation might pose, because of the benefit in local control, we have worked together to make it possible to give both modalities.
If I could just make one more comment, I think it helps explain a little bit of the rationale that, when you're thinking, particularly in the sacrum, you see the tumor on the MRI, but what you don't see are the little tendricles of the tumor that are outside of the main mass of the tumor. We assume that they're there, and in fact, there was a study out of Japan that indeed showed that there are little, what they were calling skip metastases, so I'll use that term skip metastases, but really it's the tendricles of the tumor that are outside the main mass, and that they found them up to 3 centimeters outside of the main mass of the tumor. And so there are 2 ways to treat that. You can take away all of that tissue and make sure that you're, several centimeters beyond that, and or you can radiate that area, which can kill the skip metastases. So either way theoretically can work, but the reason I thought that's so important is it helps explain why in some cases where you can get a negative margin, but 10 years down the road you can get a recurrence of the tumor, because there may be these little microscopic foci of disease that even though the surgery was very well done, there's a little tiny foci outside of the main mass. And that's one of the reasons why we believe, or at least provided some justification for why we do believe preoperative radiation can be useful in that scenario.
That actually leads directly to one of the other, I think there are a number of questions around if a recurrence does happen, when do you expect it to happen? How long down the road does that typically occur? I think probably the underlying question people are asking is, when can I feel like I'm out of the woods?
I think for our chordoma patients, you should get follow-up scans forever. It is very variable depending on the pathology, as Lenny John talked about for pediatric base of skull tumors. Sometimes we see poorly differentiated histologies that are likely to recur earlier. But in general, these tumors are slow growing, and that's a good thing because you could have a long disease-free survival. Certainly you can reduce the frequency of scans and perhaps even the length of your scan for some indications. But I think for the local area, because especially if you've had radiation, a follow-up MRI is good for following to be sure the disease doesn't come back, and also following for complications of radiation that you might catch early.
I think it's a really good point that you have to, chordoma is such a unique tumor, and I think that when you read articles, manuscripts regarding the outcomes for chordoma, you really have to look very carefully at the length of follow-up. And for most cancer studies, they usually say, well, there's a minimum of 2-year follow-up. But for chordoma, I think it should be much longer to really know how efficacious your treatment is, because tumors do tend to come back 3 years, 4 years, and we've seen cases well after 10 years. And so it's not like a lot of other cancers where recurrences come within the first couple of years of treatment. It's usually further down the road.
So my perspective, this is by definition what we call a good question. And the definition of good question is that we have no clue what the right answer is. I think the reason why the controversy continues on amongst experienced clinicians as to should you or should you not incorporate radiation therapy up front. I mean, Dr. Schwab gave some very good, compelling reasons. I think the folks who prefer not to routinely use radiation will cite long-term complications, will cite enough experience in their own practices that surgical resection alone cured some of these patients or kept them free of disease for 10 years and so on and so forth, right? So there is evidence supporting both approaches. And so the real answer to the question becomes, the devil is always in the details. How big was the tumor? What was the location? How cleanly was it removed up front? It kind of gets back to that concept we were talking about earlier. So there are examples where the first surgery cured patients, and there are examples where combination cured the patients, and then there is everything in between. So I don't know that there is a right answer to the question, and this gets back to the basic point that a group of people with different expertise in treatment of this disease have to put their heads together and say, well, what is the best approach for patient X sitting in front of them?
So we have a group of people who have looked at a lot of scans, right? A lot of MRIs, a lot of CT scans over the years. How often do you look at a scan and think, this thing looks clean, and then 2 years later you find something and then look back and say, oh, it was there all the time? Does that happen in your experience?
There's no question that you know, the retrospectoscope, as we like to say, does help when you see something that becomes definitively proven, and then you look back and say, well, maybe there is a shadow there. That certainly happens.
Yeah. I'm pointing that out because as somebody who took care of almost exclusively late-stage patients, meaning like now it's recurrence, there's metastatic disease, and we were running clinical trials to see if we could control disease, we would oftentimes feel like, hey, things are going really well, and then a year later, we'd find something that was large enough to measure, and then if we'd go back through those scans, say, actually, we could see this thing, but we didn't know it was chordoma because it looks so much like the stuff around it. So this is a real challenge with certain sites of disease in that our imaging no imaging is perfect to be able to tell the difference between certain structures in the body and a chordoma, although it's pretty good, it's very good, but it isn't perfect. So it can be really hard when something's very, very small.
I think along the lines of imaging, you know, the challenge is as patients go through surgery and radiation therapy, there can be changes that happen. We definitely see this in the skull base, and so that issue does come up, is that because of that scarring from treatment, it may mask the microscopic cells. But I think the point along those lines too is that the imaging, where you get the imaging, who interprets the imaging is important too. That's one of the reasons why, you know, certainly there are logistical challenges in terms of getting your MRI scan at the same place, read by the same radiologist, but those expertise also matter. And we always try to work with our patients to get the scans, for example, at Anderson, read by the same group of radiologists because of the complexity of those scans over time.
Yeah, that's great. So a question sort of related to all of this upfront management is, if a patient has neurologic dysfunction related to surgery or radiation, what is the likelihood of recovery of those? And I realize for most of you the answer is going to be it depends, but could you all maybe just give a little color on that it depends? Because I think this is a question on many people's minds.
Well, what I would say is that if a neurologic structure is still there, but the function is not there, then if you start to see some improvement, usually within the first year, you may see further improvement. I think that the longer that you go without seeing improvement, the less likely. I mean, these are obviously a little hand waving, but what I tell people is if you start to see some improvement early, you're likely going to get a lot better over time. If you don't see any improvement, you can still maybe get some improvement, but the likelihood starts to go down. That's assuming that the nerve is intact, and this is true with radiation. If you combine surgery and radiation, even though the nerve's intact, it may not work. It may be less able to function. It's in that scenario. So I think there's some truth to that.
All right, I'm going to pause for 1 second, look around the room. Does anyone have any confusion about anything that's been discussed so far that they want to clarify? Yeah, perfect. Oh wait, microphone's coming to you. Hang on 1 second. This is, the reason we want the microphones is so that the people viewing remotely can hear what the question is. So if you could.
I just have a question about the radiation before the surgery. It seems like you do that with sacral but not clival. Why would that be?
Why don't you go for
So I think it's really maybe more of a surgical question, but giving pre-op radiation would probably make the surgery more difficult, and it's been standard of care for years to operate first and then to give radiation. There's typically, it's more difficult to get an en bloc resection and negative margins, so adjuvant radiation's more often the standard of care. Whereas in the sacral area, we often use pre-op radiation, operate soon after, like waiting about 6 weeks, where you don't form scar tissue, but you give enough time to heal. But you are correct that it's not typically done for clival, and it is frequently done for sacral or spine chordomas.
There certainly are certain tumor types in the skull base where we do preoperative radiation therapy. I think specifically with clival chordoma, there have been two concerns. One has been the reconstruction. So oftentimes you can have chordoma that goes through the envelope around the brain through the dura, and preventing a CSF leak after surgery historically is one of the challenges after specifically doing an endoscopic resection, going through the nasal cavity and removing everything. And in order to avoid a postoperative CSF leak, that really requires having tissue that has healthy supply, healthy blood supply. And the other consideration with regards to why we haven't pursued preoperative radiation therapy is oftentimes patients will present with symptoms related to the tumor, whether it's double vision, whether it's pressure on the brainstem, the inability to walk. And the fastest way to correct those symptoms related to the question a little bit earlier on is to take a patient to surgery and relieve that pressure. And so time has always been of the essence too with skull-based chordoma. And I think so it's because of those reasons that we haven't pursued pre-op radiation therapy.
I'll add to that, what I had mentioned before about this concept of skip metastases has been much more clearly shown in the sacrum. It's not been shown in the clivus, and it's not been really shown in the spine either. Now you say, well, they're all chordomas, but not really, right? And there are differences. And so this idea of these skip metastases, particularly in the sacrum, they can grow out in some of the gluteus maximus musculature or the piriformis musculature. And that hasn't been as definitively shown in other areas of the spine. And so the rationale may not hold up in other areas to use neoadjuvant radiation. We just don't know for sure.
And just to add to that, for the sacrum, both because of these potential skip metastases, but also just the ability for chordoma to seed. The one reason radiation, for us, we prefer preoperative radiation is that when you have a tumor that you can see well and you define a rational margin, so we typically add about 3 to 4 cms based on the Japanese pathology study that shows there's these skip metastases along the muscles a certain distance out. You anticipate where the skip metastasis might be and try to design a very rational target. It generally is much smaller than what you have to chase afterwards. So typically a post-op radiation, we would chase the full incision, any type of what we call seroma, where the tumor cavity, and there may be drain sites. So those are all sites that have been observed to potentially seed, with chordoma, where a tumor can implant and grow into new tumors. And those are based on observations, from 30, 40 years ago, over decades of our mentors treating chordoma and observing that phenomena. And so postoperatively, defining a target is a bit more challenging for the sacrum because the potential reconstruction is so much greater. And the area of exposure is potentially so much greater.
Along those lines, it might be helpful also to just point out that the rate of metastatic disease for sacral chordoma is significantly higher than for clival chordoma. Personally, I've never seen a metastatic clival chordoma, meaning broadly metastatic to some other part of the body. I don't know if anyone else has. But with sacral, we had I mean, almost every patient that we had with a sacral chordoma had a metastatic site. So,
And then also, there were some very nice presentations yesterday, and one of the presentations that struck me was just the genetic variation based on the anatomic site. Clival chordomas maybe histologically are similar, but they biologically may be quite different, and that goes along with what you're saying.
Go ahead.
Just
And then just
along
for-
that, I think there may be also correlation with size as well. Some of our studies where we've looked at patients with chordoma and looked at the outcomes with correlating with size. The size actually, if you give proper adjuvant or local treatment, doesn't affect the local control, but there is a correlation with the risk of distant metastasis. So we found in one particular study that tumors larger than 500 cc's were associated with a higher risk of distant metastasis. So I think in sacrum, the tumors tend to, are able to grow a bit bigger, quite a bit bigger, before it triggers symptoms and medical attention.
yeah, so that concept is, I think, probably pretty straightforward, but I guess it's worth just pointing out that the reason for that is just real estate, right? If you had a mass as large as a sacral chordoma in your head, you wouldn't be able to survive it. Most sacral chordomas are measured in many centimeters, where most clival, by the time they get to any size at all, are already pushing on something important, and so you're starting to have symptoms, right? So if that's not clear to anybody, again, raise your hand. There were a couple of terms that we were using here that I just want to make sure that if anybody's feeling like they're lost on some of that terminology, again, we want to hear from you. And in particular, one of the things that I heard in that conversation around radiating a larger area with a sacral chordoma, and you're trying to make sure that you're kind of hitting the outside of the tumor, is that, again, this is sort of obvious to doctors, but I want to make sure everybody knows this, is that there are normal structures there, right? And so that's where these side effects and problems can happen. And so the question that was asked here about will I recover function and all of that, to Dr. Schwab's point, is it really depends on how much of that had to be hit, with what dose. And it really is important to speak with your treating physician about that. And obviously they're going to do their very best to try to reduce that risk as much as possible. But the trade-off is they're also trying to reduce the risk of recurrence. So we just want to make sure everyone's kind of level set on that point, because it's a tough one.
Sort of chiming in a little bit about the neurologic recovery with regards to the skull base. It's an important factor with regards to quality of life, right? And, what we see is typically, if you're going to see recovery, it's probably within 6 to 12 months of finishing surgery and radiation therapy. But what's just as important as the recovery is looking at, okay, what else can be done with regards to therapy, right? And oftentimes within the skull base, double vision, for example, is a major sort of concern that affects quality of life, hearing. And so part of the follow-up after finishing surgery and radiation therapy is, for example, for your team to get the ophthalmologist on board, the hearing specialists on board, so that if we're not seeing that recovery, at least something's being done to get that function back some way or the other.
Yeah, such a great point. It's actually one of the things that's really amazing about some of the clinical sites we're talking about right now is that if you ask the ophthalmologist, the neuro-ophthalmologist to come see your patient, they've seen a chordoma patient before, right? And that is a big difference in some institutions versus others. Some institutions might not even have that person. So it is just part of what we were talking about, multidisciplinary teams, and trying to make sure that everyone's coordinating your care is a really important component. All right, let's get into some specific ones then. This one is for Dr. McDonald. If you have had proton beam radiation to your skull and there is an effect on the pituitary gland, how does that affect, sort of what is the pathway that could be affected? What are the different hormonal therapies that you might need? And will you ever be able to come off of those therapies, or will you need to be on them the rest of your life?
So there are two structures in the brain that affect hormone function, the pituitary gland and hypothalamus. For pediatric patients, the hypothalamus is very sensitive to radiation in terms of the production of growth hormone, which is important for children that are still growing and should be replaced. That particular hormone, patients can come off of it after they've reached full growth, but many, about half, feel unwell when they come off of it, and then they continue it for that reason. It is rare to test that for adults or to start it for an adult. For adults, we see hormone abnormalities that are usually because of the effect on the pituitary gland, and the most common is thyroid hormone, and that hormone could become deficient years after treatment. So it's another lab that I would say don't stop testing for it. Don't think, oh, I'm 5 years out, I'm not going to develop it. It more often happens around 3 to 5 years. And that's replaced, but replaced by a very small pill. And many of you might know someone who has primary hypothyroidism because it's a common disorder, and the replacement is the same. But if you are on it, you will be on it for life. And then less common hormones, for males, testosterone is sometimes required to be replaced. Cortisol is less common but may need to be replaced. And for pediatric patients, sometimes we need to delay puberty because certain hormones are off balance, but that would be temporary. So dependent on age and also on what hormone. But I would say the other thing to know is that clival tumors that are in the upper mid-clivus are more likely to affect hormones than distal clival tumors or clival cervical junction tumors. So it depends on the location of your clival tumor. And you can always ask your radiation oncologist, what dose did I get? And they can give you, for many of the hormones, some idea of what the risk is of needing hormone replacement.
Dr. Patel.
So Gary's asking for us to elaborate a little bit on ablation. Chris, you invoked ablations, and that's what's generating this question, so I figured we might as well ask the
I'll leave it to you to
panel.
explain that.
So,
Sorry, who was, oh, okay. Yeah, so ablation, do you want to take it or do you want me to take it?
yeah, no, I think
go
what he's asking is our experience with ablation. So I'm going to kick it back to our surgical colleagues
Yeah,
to
sure.
say, have you recommended ablation in scenarios, pros and cons, as you see it in different anatomic locations?
We have, so the most common type of ablation that we use now is cryoablation. Prior to that, we were using radiofrequency ablation. And cryoablation has been around for a long time. It started at Sloan Kettering in the 1960s, but that was usually an open surgery. So now they'll use a needle under CT guidance, and this needle will then go into a tumor. They'll release argon gas. The argon gas, as it expands, it freezes, and you can see a little ice ball that forms, and that can be effective. The problem, just like all treatments, you can also damage normal structures. So if the tumor is around a nerve, you're going to freeze the nerve. So there is this balance. If the tumor is next to the bowel, you don't want to freeze the bowel because that will also damage it. So we have used it and I would say successfully in select situations where we're not going to cause harm. But so we do use ablation for small recurrences, assuming they're not next to vital structures.
With the skull base patient population, very rarely have we used thermal ablation when chordoma has spread to, for example, the bone around the spine. The reason why we haven't used thermal ablation within the skull base is related to the technology. It's just there's no means by which we can deliver that energy to cook a tumor within the skull base. That's probably the reason why it's not part of the conversation just right now in terms of treatment.
Yeah, and I'll give just a separate perspective, which is that we, in my time at NCI, we used ablation very sparingly for metastatic sites of disease that might be pushing on an important organ or vital structure, and we thought it could be addressed without having to go through a full surgery. So it was just a tool that was in our tool belt, and it was oftentimes around the decision of, we don't know if this is going to cause you a problem, so do you want to go through a full surgery? Or could we do this thing that could be done in an afternoon, and then we can watch it with scans over the next few months and see how it goes? Not a very common thing, but I just wanted to mention that it's an option out there. Any other comments on that?
Yes, just to complement that, lung metastasis is probably one of the most common locations where we're often assess if a patient has a limited number, meaning very few, then typically have a multidisciplinary discussion with a thoracic surgeon and an interventional radiologist and us in radiation, and our medical oncology colleagues as to, what is the best way to address that, if someone only has a few meds. And so that's where we see cryoablation as potentially one of the options that our patients might undergo. And then if a lung metastasis is close to the heart or one of the great, vessels where cryo may not be feasible, then that's where we might do stereotactic radiation as a radiation ablation. So there are different ablation. There's also this concept of ablation within radiation as well. But it's often kind of a team effort. It's like, which one can you get with cryo, and therefore we limit the amount of radiation the lung receive, and which ones are more challenging to cryo, and then we can take care of that with radiation.
Right, thank you. I didn't want to miss, there was one other sort of sub-question to the question about growth hormone, which is that, is there any evidence that growth hormone might actually increase the risk of relapse?
So no clinical evidence of that. It was a thought because some tumors have growth hormone receptors decades ago, but at any pediatric neuro-oncology center of excellence, it is replaced for tumors that where we affect the hypothalamus and need growth hormone replacement. And the other thing to remember is that if the patient is getting growth hormone replacement, it means they don't have it. So we don't take away growth hormone in order to keep tumors from growing. So you're really replacing what should be there.
Yeah, I think it's a great point. And this is sort of an internal medicine type of question, so maybe I'll try to help with this as well. In biology, there's not really like on-off. There's a spectrum of outcomes with any signaling pathway. And so if you push something to, an upper above where it should be, you become Andre the Giant, right, with growth hormone. If you have none, you actually don't develop appropriately at all. So it's not really an option to not use growth hormone in a child. There are lots of negative impacts of not having growth hormone. So it's not really something that I think could be ethically considered to not, especially when we don't have any evidence of it causing a problem. Any other comments on any of that before we can move on to some other topics? Cool. So
can I ask a similar question?
Yeah.
I see a lot of comments on the Facebook and Chordoma connections about using hormonal replacement to induce pregnancy. Is there a concern about that also stimulating the tumors?
I mean, I don't know if anybody, I don't think anyone that I'm aware of has ever even suggested that there is a receptor on chordoma cells that would be able to receive the signal of hormonal therapies, hormones like, that are related to the normal cycle for a woman, for instance. Like I don't think there is the receptor present to make that happen, but does anyone know otherwise?
No, I don't know otherwise. And I think you said during pregnancy, is that correct?
Or, yeah.
Okay.
No, to induce pregnancy.
To induce pregnancy.
Because her hormonal levels are low because of due to the radiation.
No evidence of that. And I have had patients who have had that done and have had healthy babies and no recurrence.
Yeah. Oh, great. So for anybody who couldn't hear that, the first breakout session after lunch, there will be an endocrinology portion as one of the breakout sessions. So if you have questions about that, please join that session. Here's a question that actually I have not come across, so I'm looking to the panel to help with. This is a question about a patient who had a clival chordoma and then was found to have leptomeningeal spread. I haven't run across a case like that, so I'd love to hear if anybody's had experience and how that's been managed. And if you could give a little bit of color about what leptomeningeal disease is and why it's tricky to manage.
Sure. So conversation about metastases also came up, and earlier on, when we look at our clival patient population, about 9 to 10% of patients, if you follow them long enough, will develop metastases, and meaning that chordomas come back away from where it originally started. Now, what leptomeningeal disease is that the brain and spinal cord is covered in cerebrospinal fluid, and that sort of is housed within the envelope around the brain and spinal cord. And so in very rare circumstances, you can have the chordoma come back in the spinal fluid, and oftentimes may get discovered, for example, on a MRI scan done of the spine because of associated symptoms. So we have seen that in our skull-based patient population. Oftentimes when we see that, we often look to Dr. Patel and our medical oncology group to look at medication or systemic therapy options to treat that.
So just as a starter, leptomeningeal disease as such is a very difficult disease to treat. I think God designed certain anatomic areas in a way to protect critical structures so toxins don't get to it, right? So the brain and the craniospinal axis, as we call it, is generally protected from drugs that we would administer in the bloodstream, for example. It may not even get there. When the membranes covering the spinal cord, the dural membrane gets involved and there is some nodularity along it, that's what we call leptomeningeal disease. The way we would historically treat it, for example, in leukemias when that happens, or some other solid tumors where it happens, you put in an Ommaya reservoir that sort of gets into the ventricle and the cerebrospinal fluid space, and you give some drugs in there so that it bathes that entire cerebrospinal fluid or cerebrospinal axis with that drug. Problem is that outside of the leukemia setup, drugs don't necessarily get there. So back to chordoma setting, in a very rare scenario like Sean's mentioning, and I think, yeah, we do have, I think, 1 or 2 at least that I can think of in our practice, we would just try to go spot welding, right? Radiation works, so we would rely on our radiation oncologists to sort of say, just radiate that craniospinal axis and let's see if we can get some control over it. But that is a very unrewarding, ungratifying kind of a situation, primarily for patients, but also for the providers.
Yeah, it's a tough. Yeah, maybe just to make sure that that point is clear, most of the time chordomas are going to be pushing in on the spine from the outside of the covering of it. And now we're talking about is when it's inside of that and has seated sort of not necessarily in one solid mass, but it's sort of creating a inflammatory, angry area inside of that, inside of the lining of the spine and the brain. Just totally agree. I have managed many patients with leptomeningeal disease with other cancers, and they're very difficult to treat. So, I think if that is a specific question for a patient, that might be one that is worthwhile to almost take separately, because it's a pretty unique scenario. All right, now we're...
Just add one comment that Sean and I were just talking about. We've really only seen it, both of us, in dedifferentiated chordoma,
Okay.
which is very rare and more aggressive than conventional chordoma. And there's another type of met you could see from a clavichordoma that is called a drop met, that would be in the thecal sac, which is the lower sac of the spine, but that would not be true leptomeningeal disease.
Okay, we're kind of into the systemic therapy, so Dr. Patel can now shine a little bit more. So first question is about developing type 1 diabetes after nivolumab. How common is that side effect? Does it ever go away? Do you want to take that?
I'm sorry, I missed the question.
So with receiving nivolumab,
Oh, yeah.
type 1 diabetes developed, and just how often does that happen, and will it ever go away?
Right, so just clarifying the concept. The concept of immunotherapy is to teach the T cells to go attack the tumor cells. Sometimes the T cells are not as smart as we would like them to. Most of the times they are. Sometimes they will go attack the normal cells, and Chris can elaborate on this, he's the immunologist. But you can get some inflammation of a variety of normal organs. You can develop pneumonia that we call pneumonitis, and then the pituitary, and we call it hypophysitis, that sort of stuff. So if the diabetes happened in the context of nivolumab, while the drug is still being given, let's just say it's helping the chordoma, then we just manage the diabetes at the same time and make it work, because the primary goal of that treatment is to control the malignancy or control the chordoma. At some point in time, when we get to an imbalance, if you will, stopping the immune checkpoint inhibitor can eventually revert that process. I think I can think of at least one case where we stopped the drug eventually, we treated the chordoma differently with some focal radiation, and the diabetes became easier to manage and eventually even did not require some active management. So it can improve over a period of time, but this is, the experience is not large enough and robust enough to sort of make blatant statements. But Chris, you may have something to add.
Yeah, no, I agree completely. So for anyone in the room who doesn't even know what diabetes is, like I didn't know my first day of medical school, diabetes is really just describing that the insulin that your body makes isn't working well enough to process the sugar that is in your bloodstream. So there are two ways that can happen. One is that your body becomes resistant. That's called type 2 diabetes, which is the most common diabetes that plagues the United States due to the way we eat and don't exercise. And then the other one, which is type 1 diabetes, is actual damage to the cells that make the insulin. And so that can happen when you've triggered an immune response. And most commonly, type 1 diabetes is what we call an autoimmune disease. So your body's immune system is attacking your pancreas and eliminating these cells. But with nivolumab and other drugs that drive immune recognition of cancer cells, they can accidentally cause damage to normal things. And to Dr. Patel's point, if you take that drug away, sometimes it can reverse and sometimes it doesn't. It just really depends. And we really don't have any way of predicting it. Now, if somebody has a metastatic cancer and it's under control, we'd rather deal with diabetes than deal with cancer. And so that's kind of the choice that has to be made. Any question on that? I would also say that what we just described about type 1 diabetes applies to the other endocrinology concerns that happen with checkpoint inhibitors as well. So they happen. The question actually was, what is the frequency of this? It's actually fairly rare. And when I say fairly rare, I mean of, say, 100 patients that are dosed with these types of therapies, a significant impact on endocrinology probably only happens less than 5 patients out of 100. And most of those are not totally severe, like a type 1 diabetes that is insulin dependent. Usually that's about 1%. The last time I looked at the numbers, something like that. So that's really uncommon, actually. Just hand him a mic. Well, all right. Now, this one's also for Dan as well. The question about EGFR and sort of where are we with EGFR? How important is it to know if a patient's tumor has EGFR overexpression when making a decision about potentially using an EGFR inhibitor? Sort of where are we? What's the state of play?
Yeah, so there is laboratory evidence that EGFR can be overexpressed and active in chordomas. There are 2 ways of addressing it. There is a pill, what we call a small molecule. There is a IV drug, which is an antibody to that receptor. Again, some evidence that one may be different, better or worse than the other. The foundation, therefore, has supported clinical trials on 2 sides of the Atlantic. Europe and EU has tested the small molecule afatinib to define its activity, and there is some proof of principal activity and some promise. We, on this side of the Atlantic, are testing cetuximab, which is the antibody to the EGFR receptor. And again, as you may have heard earlier this week from Dr. Connolly, one of my colleagues who is running the trial, that we do see some preliminary activity. I think, again, I will always make the statement that the devil is in the details. This is an ongoing study, so we need to define what truly the level of activity is. What are the consequences and side effects? These are drugs that have been on the market for some time, so toxicities are, relatively speaking, less of a concern than a pure experiment. So the primary defining factor will be, but what is the level of activity? And then comes that next step. Well, can you enrich the patient population for activity, right? If you take 10 patients and say 2 of them responded, we always go back and ask, well, what were the characteristics of those 2 that made them respond in contrast to the 8 where we didn't see a response? Could the expression of EGF receptor be one of those biomarkers? I think that will be addressed in correlative science studies. The clinical trials right now are broad-based, based on just the notion that EGFR is overexpressed, and they're unselected patients. But to what extent will the level of EGF receptor expression become a predictive biomarker, as we call it, remains to be seen. You want to add?
I think Dan wants to add something.
Yeah, I think just to add to that, I'd say there are 2 important considerations here. One is the set of EGFR inhibitors that are available and approved for use in other cancer types right now, some of which are being studied in chordoma, and the other consideration is the biology of chordoma itself. So I'm going to start there. Most chordomas have some EGFR. To the extent that EGFR overexpression or amplification predicts response to EGFR inhibitors in chordoma, it's not clear. It has not been a great biomarker in many other cancer types. So for example, in lung cancer, a certain type of lung cancer, EGFR, the gene is mutated, and that predicts that about 70 or 80% of those patients with an EGFR mutation will respond to an EGFR inhibitor. We just don't have that type of information yet in chordoma to understand how to guide patient care. So that's something that we're working on understanding in the lab right now. And this cetuximab trial ongoing at MD Anderson has a correlative aspect to it as well that will hopefully provide some insight as we move forward. The other thing, the other part of that equation is, which EGFR inhibitor is best, and that's something that we're working on trying to understand as well. What we can say is that, some of the newer EGFR inhibitors have been developed specifically to target the mutated form of EGFR that you see in lung cancer or some types of gliomas, for example. And those, we think, at least in preclinical studies, don't work as well on the unmutated form that's frequently seen in chordoma. And that's why most of the efforts to explore EGFR inhibitors in chordoma have focused on some of the earlier generation EGFR inhibitors, including small molecules like afatinib, or erlotinib, or gefitinib, and antibodies such as cetuximab. And I think those have shown in chordoma cell lines and chordoma mouse models the best effect, anti-tumor effect so far.
Any other comments from the panel? I'll add something if no one else wants to add anything. So yeah, for anybody who doesn't know what EGFR is, it's the epidermal growth factor receptor. I'm sure you all are comfortable with it. So the important thing you should know about this receptor is that it is, again, a normal receptor in our bodies, and it is there to help regrow tissues that might be broken down or something, right? So this exists for a reason, which is part of the reason you can't just completely eliminate it, because you would hurt the rest of your body. But there is an overexpression of this receptor in many cancers, and to Dan's point, in lung cancer, this is the best illustration we have, where if this thing is mutated, it's just on all the time. And you can inhibit it with a drug that works extremely well for some period of time. But in cancers like chordoma, where epidermal growth factor receptor isn't mutated necessarily, but is just more expressed than normal tissue, there's a window of opportunity to give a drug at a certain concentration that might inhibit the cancer growth without affecting the rest of the body. However, we also know that in some of those cancers, if you give that drug, people will get a rash, for instance, a very bad rash. Now, interestingly, that rash also tends to predict that the drug will work in your cancer. So it's kind of a, you're good if you do, you're good if you don't, and you're also damned if you do and damned if you don't, right? It's both. So it's a real challenge. There are ongoing investigations about how to prevent the rash in other parts of the, on the skin while also treating the cancer. That's a very interesting field of study right now. Last thing I want to say about that is all of the drugs are not the same and how they work are not the same, but the small molecules like Dan was referring to, they work by trying to stop the signal from getting down inside the cell to tell the cell to keep growing. And then the drugs that are called monoclonal antibodies bind to the outside of the cell. And they actually serve more as a tag to tell the immune system to come and eliminate that cell. So they actually work in very different ways. And it's part of the reason we thought it'd be very interesting to conduct this trial of cetuximab, which is a monoclonal antibody, even though we haven't seen as much as we would like out of some of the EGFR small molecule inhibitors. So again, and those biomarkers may be very different depending on which of those interventions we use. So stay tuned. I think this is a developing story. And I think obviously you all weren't here for the presentations on the scientific side, but I think we can say with some degree of confidence that cetuximab, a monoclonal antibody for EGFR, could work for some patients and probably does work for some patients. And to Dr. Patel's point, it's really important to figure out who those patients are, so we're not giving a drug that might cause side effects to people it won't help. Everybody got all those concepts? A lot of easy stuff. We're just like 12 years of oncology training for everybody. We'll just get you there. All right, so this one I think is one of the ones that a lot of people want to know about. Does a chordoma ever go from slow growing to fast growing? And what does that mean if it does?
I mean, I think that in the recurrent setting, we certainly see that where they become more aggressive. But usually that means they're either becoming a dedifferentiated chordoma or a poorly differentiated chordoma. So they do undergo a biologic change. If you have a slow-growing tumor that you've been following, and then it starts to accelerate, that can occur, and it usually means that there has been a change in the biology of the tumor.
So it's not a common occurrence. I think the dictum we teach fellows and trainees, generally speaking, once a chordoma, always a chordoma, right? So histologically, it remains the same. The time to recurrence can change. That is, if it took 7 years for the first recurrence to happen, the next recurrences typically happen at shorter and shorter intervals. But that's true for malignancies in general, and chordomas will follow the same suit, just spread out over a longer period of time. Having said that, like Dr. Schwab was saying, we actually have encountered a patient very recently where that conventional chordoma sort of now, one of the later recurrences just is behaving far more aggressively, and rebiopsy of that shows spindle cell sarcoma kind of appearance in there, to sort of describe it more simply, although that may not be simple enough. That's the term dedifferentiation. It's transformation from a not so angry looking tumor to a far more angry looking tumor. And as expected, they tend to behave with faster growth. Maybe the probability of spread to other places also goes up, and the treatment paradigms may then sort of shift to just like treating an aggressive malignancy more so than the typical chordoma rules.
And maybe I'll just pose this as a question to the clinicians on this panel too, because as a scientist, to me, if someone has maybe a conventional chordoma that then starts growing very quickly and remains a conventional chordoma, that might suggest that, so these tumors can be very heterogeneous. They can consist of multiple different types of tumor cells. That maybe suggests that a new subtype of tumor cell has started to grow out very rapidly, potentially with a different drug sensitivity. So What are your thoughts on, molecular profiling and what should be done in those circumstances?
I think clearly from an understanding standpoint, that's a very good idea. That's the only way we will understand. The translation, or a good example of that, is the colon cancer model, right? So there is a benign lesion in the colon that's just an adenomatous polyp. That adenomatous polyps becomes atypical with some cellular characteristics that now are acquiring some badness, to keep it simple. This degree of badness keeps getting worse until it ends up becoming a colon cancer. And that whole model has been very well established, that with each step of transformation, the tumor acquires some new genetic abnormalities that may be very heterogeneous. Some of them are very consistent, but that's what happens. The tumor keeps acquiring some genetic transformations that are then reflected as badness in terms of what it looks like under the microscope and badness in terms of how it behaves clinically. So to Dan's point, I think we did biopsy this patient's tumor with the dedifferentiation, because histopathologically, that's how we documented dedifferentiation. We'll run it through the sequencing and see what we find. The problem with that is this is uncommon enough, right? So we will have anecdotes, but this is why in most experimental trials, we would prefer to get biopsy up front, biopsy on treatment, biopsy after treatment to see what kind of genetic changes are happening. The concern with chordomas is that they tend to track along biopsy tracks very commonly. So you want to sort of reserve that sort of an approach that is purely research and not helping the patient, only in scenarios where we're not going to do any harm, and the knowledge gained will be a net addition to the whole understanding of the process.
Great, thank you.
I'll just make one comment. For my pediatric colleagues from the NCI and I were speaking yesterday about unusual rare cases in children that are conventional and do sometimes grow quickly. And I think that's something they're going to look into further with their data that they've collected.
I think that bridges nicely to a question that probably a lot of people have around when do you use a systemic therapy, and what is sort of the goal of care with a systemic therapy approach?
I can start, but so I think the simple answer would be when the local therapy experts tell us that there's no hope there, that's where we sort of start systemic therapy. If you look at just historically, drug therapies have not been very effective for chordomas for a long time. It's nice that, again, primarily with the help of the foundation now, we are learning a lot more about what targets may be relevant. We're learning which drugs to use and how. We're actually conducting clinical trials to sort of do it in a scientific manner, so we have some level of confidence in the recommendations. But systemic therapy, as of right now, is used after failure of local therapy and where local therapy is not very helpful. So if it's surgically addressable, we try that. If it can be radiated, we try that. We even talked about ablations if there is a small focus somewhere. So let's just say it's a sacral chordoma and there are 2 lung metastases. If there's a clinical trial and there's a reason to experiment with drug therapy, I think that's a rational, reasonable way of approaching it. But if the clinical trial was not available, for example, just doing either ablation or focal stereotactic body radiotherapy, like Yenlin was saying earlier, could be a way to just bridge the gap for the time being, sort of thing. So systemic therapy remains an approach of, for lack of a better term, last resort. The hope is that if we when we find the right option that has good therapeutic index, level of benefit is good, downsides and toxicities are not that great, that would be the scenario where we now sort of incorporate it early on, right? That's what we do for other bone tumors. That if we think that the risk of failure is high, the idea is to empty both barrels or 3 barrels up front rather than save it for later, right? That was a conversation about radiation and surgery that we were having earlier on. So one could envision that if either immunotherapy or EGFR inhibitor therapy did show promising activity in a defined patient population where the predicted risk of recurrence is high, one could incorporate it earlier. So that's the future, if you will. But as of right now, systemic therapy is recommended when we have ran out of options with local therapy. Anyone disagree or different opinions?
Just as the pediatric oncologist on the panel, with the exception of poorly differentiated pediatric chordoma, which is a subtype that's very responsive to chemotherapy, and we even sometimes use chemotherapy as the upfront neoadjuvant therapy before surgery for these patients. They also show loss of INI-1, which makes the targeted therapy tezemetostat an effective therapy, and have other, down the line therapies that may be more effective. And I think my NCI colleagues pediatric colleagues could comment further if there's anything else you have to add.
Just chiming in a little bit from the surgery perspective, I think historically, we really wouldn't get our medical oncology colleagues involved earlier on. We used to just rely on repeat surgery, repeat radiation therapy over and over again for patients who develop multiple recurrences. And I think a lot of that probably stemmed from the fact that there weren't a lot of systemic therapy options. There weren't a lot of clinical trial options a decade ago or so. And then about 9 years ago or so, we looked at our own experience with, how do patients do with repeat surgery and repeat radiation therapy for someone who's developed recurrence, local recurrence. And we got a better sense of when does a repeat surgery make sense, when does repeat radiation therapy make sense. And one of the lessons we also learned earlier on, and looking at the context that there are now more clinical trials looking at systemic therapy options, is to get the medical oncologist on board much earlier on in the disease course, oftentimes at first recurrence. So before putting that patient through repeat surgery, repeat radiation therapy, to see is there a clinical trial option that we can consider in addition to using what we already have in our toolbox. I think that's why sort of our thought process has changed, fortunately, over the years in terms of when to get systemic therapy options on board.
I would echo that in that from the radiation standpoint, the initial dose necessary for controlled chordoma is already quite high. And that's even in the setting of, a complete surgery, and the dose goes, higher if you're doing treating it for positive margin or definitively. And so the ability to repeat that radiation is essentially limited probably to just another course, typically still constrained by what the normal tissue or organ can tolerate. And so the longer you can delay that, having to do that re-radiation, if there are other options that can temporize, that's something we consider, because the potential complications such as soft tissue breakdown, bone necrosis, neuropathy, those go up, bowel toxicity, bowel breakdown. So that's one way. And the other comment just would make is that even in a metastatic setting, what our medical oncologist has done is we remain very closely working together. So if someone's on systemic therapy, but perhaps just one or two spots are starting to take off and start to cause trouble, then we can go after those. And so it's still a collaborative effort, even in a metastatic setting.
I'll add just a little bit of my thoughts there. I don't know, I don't want anyone to generalize thoughts too much on this, because every patient has to be thought through very individually in this. But if you have a very, very slow growing, metastatic cancer, for instance, you actually don't need systemic therapy all the time. Sometimes you do, sometimes you don't. And so it's really important to think about how fast is it growing, where is it growing, when is it going to cause a problem, because therapies come with their own side effects, right? So sometimes you do need a systemic therapy to try, because you know that the alternative is that there's going to be damage to an organ, or there's going to be a fracture or something like that. And so I think it's very important that as you think about systemic therapy, you're also thinking about what is the thing that will hurt me or kill me, right? And I know that's not the easiest topic to discuss, but whenever we're talking about therapies for cancer, we really have to think about what is the thing that is going to hurt the person or kill the person. And what we observed in my practice was that most patients were being hurt and hurt eventually leading to potential death by the recurrence of their local tumor mass in somewhere that was going to really cause a compromise of their neurologic dysfunction or bowel or bladder function or something like that, or in their head, obviously. But if somebody had a metastatic site in their liver and it was growing, it'd get 10% larger every year, you can live with that. So it's a balance that you really need to think through. Now, I want to maybe bring this back to why it is so important for us to develop systemic therapies. And that is because there are definitely going to be patients that need a therapy that we can't address something locally anymore, or that we can move that therapy to, remember the thing I started with, neoadjuvant or adjuvant therapy to try to increase the chance of cure. So when we develop these therapies, we develop them typically at the end of a case of a cancer, because that's where we can see the effect most rapidly. But ultimately, what we want to do is increase cures. So we want to be able to use those therapies safely at the beginning, so to Dr. Patel's point earlier, to increase our chance of cure from whatever it is today to much, much better than that a year from now, or 2 years from now, or 5 years from now. Any questions on any of that? Because I want to then dovetail. Yeah, go ahead. Oh, I need a microphone over here if anybody has one. Or I'll just repeat the question. Go ahead.
I have a question about chordoma here. So it's very obvious that a multidisciplinary team is needed with deep knowledge of chordoma. However, it's not always feasible to travel to a big institution to receive care. So my question is, how can we incorporate the chordoma expertise in every treatment plan of a chordoma patient? Can chordoma experts guide the treatment in a different institution?
That's a great question. I think Dr. Patel has probably done that a bit. I bet the radiation oncologists and this. Now, surgeons, it's pretty hard to replace, right? That's one of the great things about being a surgeon. You're always going to be necessary. So maybe we can get the comments from anyone who has a comment. Go ahead.
Right. No, it's a very good point, but I'm sure every one of us sitting here at this table get these questions or requests from all over the world. We are all happy to help. There may be limitations in terms of what can be done and things like that. I think it's not a good substitute for the actual visit and the true multidisciplinary opinion. But, settling for the next best, if you will, if that's the only thing that's practical and feasible. I think in most countries, even the regional experts sort of lend their expertise even when the patient is not really in front of them. Interestingly enough, at least in the United States now, for several other rare tumors, like Ewing sarcomas, for example, there is a tumor board that exists. And it's a virtual tumor board where one can just present the case and get some input. It may not be as specific and as detailed as one would like, or there is always going to be some reservations in terms of making definitive recommendations, but the guidance and the broader guidelines can certainly be provided. Yeah.
I think having multidisciplinary virtual tumor boards with multiple institutions for rare diseases is ideal. Clearly time-consuming for physicians and something that is not a routine part of our job, but I think we all want to help anyone we can with this rare tumor. So I know that we have one for base of skull chordoma. The NCI joins, and many physicians who have come to this meeting join it as well. So I think collaborations, tumor boards that are carefully de-identified because you're sharing information, but that's one way to do it. But it is extremely important for any rare disease to be able to collaborate with experts and to give that information to others who can't fly or travel. And the best way to communicate that information is after a educational tumor board.
Shannon knows everything, so you find Shannon, you get your answer.
You know, I think it's such a great point that you just made, Dr. McDonald, about this being a common theme for rare tumors, is that we tend to think chordoma is so rare, who could ever understand what we're dealing with? But almost all sort of ultra rare cancers like this go through the same series of problems. They're different problems sometimes, but the overarching problem of how do we coordinate care and how do we make the best decisions and how do we apply the science that is moving very, very quickly to individual patients, those are common themes across rare cancers. And I hope that other rare cancers look to the Chordoma Foundation as an example of how to do that. And in fact, I know many of them do. But also about how we unify amongst rare cancer foundations to take advantage of these infrastructures that we're trying to build. Obviously, these are expensive things to do. And one of the things I think all try to do is help facilitate bringing in new members of that community, maybe pharma companies or biotech companies or donors or whoever it might be that can help facilitate that infrastructure growth. So it's a great question. And I think in socialized countries, like socialized medicine countries, it's actually easier than it is here because medical records can be exchanged easier and all of that. But I think you've heard from people like, this is a community of doctors that are more than willing to go the extra mile for the patients. So, and I've personally been a part of many cases where we've helped coordinate care in patients and their local oncologist, and then they'll come for big decision points back to the other site, right? So I think that's the best we can do in this country at this moment. But in other countries, I think it's honestly a little bit better already than it is here. We have about 4 minutes left here. I wasn't sure we were going to fill the whole time, so I'm proud of us. But I'm going to use the last couple minutes to ask maybe Dan and Dr. Patel to talk about what we learned about systemic therapies and in our scientific conference and what that might mean over the next 3, 5, 10 years.
It's a good question. Hard to distill into 2 minutes or so.
And you just wasted 20 seconds of it. So. Better hurry.
Well, the bottom line is we learned a lot. And sort of so we learned a lot about how to better subclassify chordoma tumors so that, getting to the question about which patients benefit from EGFR inhibitors, and that extends to any drug, right? How can we understand the different subtypes of chordoma that have both prognostic and therapeutic relevance? And once we understand that, we can kind of dig down deeper and understand, okay, what are the potential vulnerabilities inside each of those subtypes? And there's also a number of new targets being discovered in that context that are being evaluated in our lab and in other labs around the world. And those, I think, from a scientist's point of view, and Shreyas can speak to kind of what's on the immediate horizon perhaps, but on more of like the 1 to 5 year horizon, there was a number of exciting things that were discussed. And what was particularly interesting to me was that about 2 or 3 kind of common themes crystallized in the research workshop where seemingly different aspects of chordoma biology all intersected into one potential therapeutic vulnerability. So I think the question for us scientists moving forward is, well, what's the best way to both learn more about the biology around that potential therapeutic vulnerability, and then what's the best angle to attack it from? So lots of stuff to go back and work on in the lab, and I think lots of excitement in the path forward.
Fully agree. And I think if you just look at it in tiered fashion, right, the lowest hanging fruit is the existing drugs that are commercial and available. I think we're starting to define the activity of immuno-oncology drugs, define the activity of EGFR inhibitors. Those are the things that can be of relevance tomorrow, next week, next month. The next tier is, as Dan mentioned, that there are some targets that are emerging that would be the next level of investigations, if you will. There are some products related to those targets that are in very early phase clinical trials. Those companies are struggling to try to develop it. The logistics of the finances and so on and so forth need to be worked out, but that could generate some additional options for patients who need them. And bringing that back to a full circle, like the immunotherapy session yesterday kept talking about what cells are in there, what do those cells do, what do they mean, who do they interact with? Well, does that understanding at the cellular level help us improve that immunotherapeutic option, for example, that comes back to the clinic and the patient? So I think progress is happening on multiple fronts. Some things are going to deliver results earlier, other things are promising in the future, and there may just be some sky in the pie or pie in the sky kind of things that may or may not work, but at least there is some progress along those lines. Joe, you have anything to add?
I mean, I'm optimistic. One of the things you mentioned earlier that the surgeons are indispensable, but hopefully not. Hopefully we are dispensable, right? I mean, it would be great if systemic therapy, we don't need to be so aggressive with surgery. And I'm a surgeon. I love surgery, but it's, it can be fairly ablative. So I'm optimistic, especially you mentioned the immunotherapy session yesterday. There were, I think, a lot of really important things discussed there, and I do think that there's reason for hope, and I'm optimistic.
That's a great way to end. I'd like to thank our panelists for all the great comments. Do not leave. Do not leave. Shannon has to tell us a few things that are really important, so listen carefully.
Well, first, thank you all. Really wonderful session. So before we eat lunch, we're going to take a group photo, and that will be in the room next door where lunch is, but don't get distracted by the food. Follow the photographer's directions. We'll make it as fast as possible, and then we can eat. After lunch, we're going straight to breakout sessions. We don't come back here. So when you hear the chimes around 12:35 or 12:40, please start going to your breakout session. Look at your agendas for the descriptions and the location, which room they're going to be in. And then you'll notice that sessions 2 and 3 are 45 minutes long and they repeat twice, which means that you'll have 2 blocks and you can choose a different session for each block. So you'll have 2 to go to there. But yeah, that's it. Enjoy lunch. See you for the picture.